Thank you all for being here. I really appreciate you all being present here to hear my presentation. I know you all are very busy, so without further ado, let us go ahead and get started. Today's discussion will be specifically about the effects of hemodynamic regulation on heart failure. So the big question is, what is heart failure? When the heart muscle is diseased or it is injured, its ability to pump arterial, oxygenated blood and nutrients to vital organs is compromised. So essentially, without adequate perfusion of nutrients and oxygen, organs will not function well, and consequently, they are going to fail, resulting in this constellation of signs and symptoms related to heart failure that we will discuss a little further in the presentation. Now, the priority concept for this chapter is alteration in perfusion. And so when you think about whether you're thinking about aortic stenosis, dysrhythmias, hypertension, coronary artery disease, these conditions cause low perfusion states, resulting in organ dysfunction. And of course, the classic signs and symptoms of low cardiac output are very similar amongst these various conditions. So the perfusion concept exemplar, of course, again, is heart failure. It is also referred to as pump failure or the inability of the heart to work effectively as a pump. There are two major types of heart failure. There's left-sided heart failure. And when you think about left-sided heart failure, think about lungs. The signs and symptoms that you will see are related to the lungs. The other one is right-sided heart failure, and of course, you will see venous congestion signs and symptoms for this type of heart failure. So before class, I typically tell students to do a quick A&P review of the system that we are going to be discussing. All right. So to gain an appreciation for heart failure, students should know the direction of blood flow through the heart, because when forward failure occurs, blood will begin to back up into the lungs and also on the venous side of the heart. And of course, the signs and symptoms that are associated with the two sides of heart failure will become apparent. Now, what I also want you to do is I want you to think about, well, first, look at these arrows. The arrows are pointing in a unidirectional, they are unidirectional, going in one direction. All right. Now, when the heart is impaired and it cannot pump blood forward, just think about these arrows now going in the opposite direction. And this is where the congestion comes into play. All right. Now, heart failure was commonly known as congestive heart failure or CHF, but these terms are not commonly used today. Now, the two subtypes is what we hear in the clinical setting. A patient can either have systolic heart failure, and this is essentially the inability of the heart to squeeze, all right? And then, of course, you have diastolic heart failure, and this is the inability of the heart to relax and allow the ventricles to fill with an adequate amount of blood. These are the two types. Now, a patient can have one or the other or both. And the consequence of this is a reduction in cardiac output, which leads to an alteration in perfusion. All right. So in order to improve or to increase the cardiac pump to make it more effective, there are three hemodynamic regulatory concepts that we must discuss. Um, and these concepts, of course, are central to this discussion today. The first concept, hemodynamic regulatory concept, is preload. Now, preload is the volume of blood that is returning to the heart, to the right side of the heart from the inferior and superior vena cava. Now, what we will do is have a brief discussion about the treatment options here. But before we get into that, what I would like to do is show you a depiction of what this preload looks like. All right. So from the superior vena cava and also the inferior vena cava, blood is returning to the right side of the heart. That that is returning to the right side of the heart is known as the preload. It is that volume of blood. This preload essentially sits in the right ventricle as well as the left ventricle. But today I want to speak more specifically to the left ventricle. All right. So preload again is that volume. Sometimes that volume exceeds the capacity of the ventricles. All right. And this is what can cause congestion, especially in a patient with an impaired heart. When someone has a significant amount of preload, it does impact the cardiac output. It also impacts the cardiac conduction system. All right. And so what we would do, and let me back up a bit. This causes an increase in preload volume causes the heart to work harder than what it should. So let me take you back to some of the treatment options here. All right. So one of the treatment options is a diuretic. Diuretics can reduce the intravascular volume, and this, of course, will reduce the preload. And so the heart essentially is not overwhelmed with an excessive amount of volume. Now, there's another way we can reduce the preload, but it's not by excretion, but we reduce the preload by slowing down blood return to the right side of the heart, and we do that with vasodilators. And let me show you quickly what that would look like. All right. Let's see. I want to increase the size on this one. All right. So when we give a patient, all right, let me back up. So as I told you, the heart is overwhelmed with so much volume, all right, in the left ventricle, the right ventricle. In order to reduce that preload, we want to delay the return of blood to the right side of the heart. So what we do is we give these patients drugs, nitrates, to dilate both the arteries and the veins. Because of that enlarged vasculature, it takes the heart more time to fill that enlarged space. And because it takes time to do that, it would likewise take time for this blood to return to the right side of the heart. And so what we're trying to accomplish here is we are trying to delay the preload coming to the heart while the heart works on the preload that it is already that already exists within the heart. All right. Let me go back. I'd like to continue with the other modalities here. So fluid restrictions is one of the ways we can reduce the intravascular volume. All right. The other one is sodium, a low sodium diet. Sometimes we place these patients on a salt substitute diet. And the thing you need to know about salt substitutes is that they do contain potassium. Now, the problem here is these patients who have heart failure are placed on a medication called ARBs, aldosterone receptor blockers. And what this medication does as far as the mechanism of action it causes a decrease in sodium, but the absorption of potassium. All right. So it is possible, especially if these patients are placed on aldactone and they are also taking salt substitutes along with taking an ARB. And so we really have to watch their potassium levels. All right. So that is preload. The next hemodynamic regulatory concept is afterload. Afterload is resistance, that resistance kind of pressure. And there are three elements that contributes to afterload in the arterial system, all right, at least on the left side of the heart. Blood contributes to this afterload resistance because blood is viscous. The viscosity of blood is thicker, if you will. Then there is aortic valve. The aortic valve is located on the left side of the heart, and that is the arterial side where it is a high pressure system. And it takes quite a bit of strength from the left ventricle to push the doors of the aortic valve open to eject its contents into the arterial circulation. So that also contributes to the afterload resistance. The last element that contributes to afterload is the arterial lumen size. And what we're talking about here is the size of the arteries. When the arteries are very constricted, then the resistance is going to be much higher. If the lumen size of the artery is dilated, then the resistance is much lower. And so before getting into some of the treatment options here, what I would like to do is, again, take you back to this image here. All right. So on the left side of the heart, again, we talked about the preload, which is this volume here. When the left ventricle squeezes, it has to eject its contents. It has to overcome that resistance that is in the arterial system. And remember, I told you that blood, um, we talked about the lumen, size of the artery, as well as the aortic valve itself contributes to that resistance that the left ventricle must overcome in order to eject its contents into the arterial system. Now, there is one of the elements of the one of the elements that contributes to afterload can be manipulated. For example, the lumen, the size of the lumen of the artery. If you look at this particular example here of an artery, as you can see, this artery is more narrow or constricted. This would cause an increase to the afterload. And so we give these patients a vasodilator in order to reduce the resistance. Now, the problem with this resistance or this afterload, uh, the problem is when that afterload pressure is too high, it causes it has an increase it causes an increased workload on the ventricles. All right. And that increased workload actually impairs or it injures the heart. All right. And this is why we cannot have a high afterload. We have to reduce the afterload. And we typically do that with medications. And more specifically, we dilate the arteries. Let's go ahead and go back. All right. So some of the treatment options is nitrates, such as calcium channel blockers, and this dilates the smooth muscle part of the arteries. All right. There's also ACE inhibitors, for example, enalapril. And what this medication does is it stops the conversion of angiotensin 1 to angiotensin 2. And of course, this causes vasodilation, which will reduce the afterload. An ARB will cause a reduction in blood pressure by excreting sodium in water and therefore lowering the blood pressure, and which will also decrease the afterload as well. And so the left ventricle does not have to work too hard to eject its contents into the arterial circulation. And so the last hemodynamic regulatory concept is contractility. This is the contractile force of the heart muscle, all right? And going back to our image, the heart is a muscle, as you all know. And when the heart muscle's contractile force is weak, we have to give these patients, we give them medications in order to strengthen the contractions of the heart. When the contractions are too weak, it will impair the cardiac output and thus perfusion to our organs and tissues. So the treatment options will be, for example, cardiac glycosides or digoxin, right? Digoxin works by increasing the contractile force of the heart, thereby improving the cardiac output, right? As far as those, the two of the hemodynamic regulatory concepts, preload and afterload, this is a great depiction of what that looks like. As you can see with preload, it is the volume of blood that is being poured into the heart, all right? And then, of course, this preload has to be ejected, for example, from the left ventricle against resistance leaving the heart. This is referred to as afterload, or that resistance to the left ventricle, which must be overcome in order to circulate the blood. So this is really a great depiction here. All right. Now, there are some other terms that we use to measure the volume of blood leaving the heart. The first one is known as stroke volume, and this is the volume of blood that is pumped from the left ventricle per beat, and that amount is between 60 and 100, or the normal amount. The next one is cardiac output. This is the amount of blood the heart pumps throughout the circulatory system in 1 minute, and that value is between 4 and 8 liters per minute. And of course, the last one is ejection fraction. Now, this is the measure that is expressed as a percentage of how much blood the left ventricle pumps out with each contraction. And the normal range is between 55 and 70%. Let's look at the etiology of left-sided heart failure. The typical causes are hypertension, and this is because the arteries are very constricted, and so this increases the afterload. The next one is coronary artery disease, and this one more or less works just like hypertension in the sense that the coronary arteries become narrow due to plaque buildup. And so it works similar to hypertension in that it causes an increase in afterload because the lumen of the artery is smaller. All right. And the last one is valve disorders, such as aortic stenosis. Um, and what happens here is if the aortic valve is stenosed, right, and the left ventricle squeezes, it is very difficult to push blood through that very narrow opening, thus placing more workload on the left ventricle. And again, all of these causes here will increase or rather decrease the cardiac output. And of course, again, the consequence is an increased workload of the left ventricle. These are some of the clinical manifestations of left-sided heart failure. And essentially, what I want you to think about is the signs and symptoms that you will see is related to poor perfusion to our organs and tissues. So when someone is weak and fatigued, they just have poor perfusion to their muscles. There is also dizziness. These patients are not perfusing their cerebrum or their brain. And the same with acute confusion, there's this low output state. There's also pulmonary congestion because blood is backing up from the left side of the heart and into the lungs. And of course, this increased volume will begin to seep into the lung tissue and alveoli, again causing congestion. Then you have oliguria, and this is because there is a low perfusion to our kidneys, which now cannot make enough urine. And then, of course, the last one is an S3 gallop is auscultated. Um, and this is a heart sound that indicates early diastolic filling. The next one is right-sided heart failure, and the etiology is left ventricular failure. Uh, Left ventricular failure, when it is not fixed, it is going to cause increased pressure for the right ventricle to push its contents through the pulmonary circulation and then, of course, to the left side of the heart, which is now congested. Right. There's also right ventricular MI that causes right-sided heart failure. When the right ventricle is damaged from an MI, it fails to pump effectively. There is also pulmonary hypertension, and so the pulmonary vasculature becomes very constricted, and of course the left ventricle has to push its contents through the constricted vasculature, placing more pressure or workload on the right ventricle. And of course, the consequence of this is right ventricular enlargement and also damage due to the increasing or that significant workload. Right. So there is increased volume and pressure on the venous side, which leads to, of course, one example is peripheral edema or that venous congestion. Some of the right-sided heart failure clinical manifestations is JVD. Remember, everything is backing up. There's ascites or third spacing. Again, fluids are leaving the vascular space and seeping into the peritoneum. Here, with as far as dependent edema, blood is the liquid part of our blood. It because of all that the pressure in the lower limbs, it moves from the vasculature into the interstitium or second spacing. There's also hepatomegaly, and this is due to liver engorgement. Fluid is backing up on that right side. Anorexia, because GI tissue becomes edematous, taking up space, and therefore these patients are anorexic. And then there's increased LFTs due to liver engorgement. All right, let's talk quickly about the compensatory mechanisms. When the cardiac output is insufficient to meet the body's demands, these are some of the mechanisms that operate in order to increase or improve cardiac output. And we just talk about one of them at this time. So what happens here when our tissues and organs are not being properly perfused? There is a mechanism, a compensatory mechanism referred to as sympathetic nervous system stimulation. This causes catecholamines, which is a hormone, to be released. And what these hormones do is they attach to the receptors on the heart, causing an increase in heart rate. And this, of course, makes the heart work harder, requiring more oxygen. The catecholamines also attach themselves to the smooth muscle part of the arteries, and this will cause the smooth muscles to contract or constrict, and raising the blood pressure. All of this is in an attempt to improve the cardiac output. And so when the blood pressure is high, this also increases the afterload, and it places more stress on an already ailing heart. Now, this will improve the cardiac output and perfusion, but it also causes an ailing heart to work that much harder. Right? And so what I just discussed with you was the adverse effects on an ailing heart. And again, that is due to the increasing workload of the heart. And so we have to think about or consider some of the drugs that is used to counteract this response, because if we allow this to go unabated, then the problems that these patients will run into is increasing workload on the heart, and the heart decompensating even more. Now, the next couple of slides, actually, what I do with students is I do a group activity regarding the medications, and so here I would put them into groups, and I'll give them one medication. That would be one medication per group, and we'll do it by classifications, and they will have to do more or less a data dump or information dump. They will have to tell me. What are the indications, the mechanism of action, side effects, nursing implications, special considerations, as well as expected outcomes. And of course, I can add to this information, especially if I notice that there are some gaps in what they provided. And I thank you for participating in this presentation.